colleagues, friends online and here in Dubai physically. And Saturday, second day of our meeting, and starting slightly late, I think because of make sure everyone's here. The first session will be, so yesterday we've covered almost everything. I think some important complications remain. So today morning we'll have session on coronary perforation, and with us we have panelist, my colleague Dr. Walid Kadro. He's a senior interventional cardiologist. I think yesterday gave us a nice talk, and today will be a panelist with us. And we also have Khalid bin Thani, but waiting for him to come. We have a recorded talk by Muhannad Egrid. He's a professor of cardiology interventionist. He's from UK, and his talk will be coronary perforation tips and tricks, followed by two cases from Turkey and Bahrain. So we can start the Dr. Muhannad presentation.
I'm Muhannad Egrid, professor of interventional cardiology and cardiovascular medicine, a consultant interventional cardiologist at the Freeman Hospital, Newcastle upon Tyne in the UK. I'll take this opportunity to thank Professor Abdullah Shihab for the opportunity to present to you in this great meeting. My task today is to speak to you about coronary perforation tips and tricks. These are my conflict of interest. This is how I'm going to talk about this. I'll try to talk a little bit about definition, the incidence, the predictors of perforation, the mechanisms and classification, and then spend a little bit more time about how we manage perforation. Before I start, complications happen all the time, and it's all about the prevention and trying to minimize this from happening. Of course, prevention starts by being in control, being meticulous, and really careful what you do, and treating every case at its merit. To be prepared and to have a plan for every patient, by knowing the patient and also knowing all your equipment, and of course, not cutting any corner. But of course, even if you do this, complications are going to happen. And when they happen, you really have to be careful and don't panic. The first thing to do is do not be in denial. Stay calm and own the complication and manage it well. Be the leader in the cath lab, because if you show any weakness or any hesitation or nervousness, that will reflect into the team. It becomes difficult to manage. Give a clear instruction, consider the worst case scenario, and be very meticulous. And of course, remember, there's no shame in calling for help and asking colleagues to come and give you a hand. And how can you be prepared? By knowing what can go wrong with the case, by studying it and knowing the patient and knowing the whole situation. And you have to always think, do I have the technical expertise to deal with any specific complication? If you're not prepared, do not do a case if you think you cannot handle some of the complication. Not all of us are prepared to do a certain procedure, for instance. Also, do I have a strong team around me, a supportive team? Does my institution have the capability to deal with any complication should it occur? And if we focus on the perforation itself, having all the equipment available like coils, covered stent, thrombin, circulatory support are important. And in being prepared and trying to prevent, when you're doing any angioplasty, you have to always take a test, for instance, to minimize the chances of complication. If a balloon ruptures, take a test. If you go to high pressure inflation balloon, take a test. If you use any adjunctive devices for debulking, take a test. And with this in mind, let's go to talk about the perforation here. The definition is easy, really. It's any extravasation from the coronary artery that happens during or following the PCI. This is an important point. It doesn't always happen during the PCI. It could happen a little later, particularly with wire perforation. Some examples here, as you could see in the pictures. And the incidence reported to be between 0.2 to 0.9%. However, it's much higher in CTOs, and some of the studies like Open CTO reported 8.8%. This is due to the fact of what you are treating. And there's an associated high risk of in-hospital mortality and MACE, and also because it leads to tamponade, hemodynamic compromise, and even death. And of course, there are predictors that you could think what can cause the perforation. They are clinical procedures and most importantly, the operator. The clinicals influence, the most important one is calcification. It's always known that calcium is the enemy of angioplasty in a way and the enemy of all interventionalists. Complex lesion, coronary CTOs, chronic CTOs, age, elderly, because they're usually more complex disease and more calcification, female, gender, hypertension because of tortuosity, acute coronary syndrome, and heart failure. Procedural factors include the using any adjunctive devices like rotablation, laser, or orbital atherectomy. If you oversize your devices, you could run into trouble and cause perforation. Hydrophilic wires could cause distal perforation. 90% in some of the reported series were hydrophilic wires. If you use stiff wires like CTOs, because they are very stiff, obviously could puncture and cutting balloon. And I put the operator in red because we really, in 90-95% is what we do, and how we do it could lead to the perforation, despite all the clinical and the procedural factors. What about the classification? We could classify perforation according to the location or anatomy. Location basically is if it is a proximal large vessel perforation, distal vessel, or collateral. And this is important how we treat them because they are a little different. And of course, they're the morphologic, which everybody would know about the Ellis classification. There are three of Ellis classes. Little one, which is number 1, then number 2, which is pericardial or myocardial blush, and number 3, the frank streaming of the contrast through more than 1 millimeter exit. And of course, that could include also spilling into a coronary sinus or a cavity. And to put it all together, the location, as we mentioned, proximal or mid vessel or distal vessel, end hole or collaterals, and also whether the pericardium is intact or post-pericardiotomy, particularly post-CABG. This is quite important because perforation in post-CABG can be catastrophic and could quickly deteriorate, or the patient could quickly deteriorate because it causes a focal collection and loculated one that could be difficult to reach because of the pericardium is stripped. And of course, whether the wire is across the vessel, which means maybe treatment a little easier, or there's no wire, you have to rush and put the wire down. And of course, once the perforation happens, you have to have the steps or the algorithm in your mind, what you need to do. And here's some of these in general. I didn't put them in particular order, but the most important one, the number 1, this is the most important one, which is balloon tamponade. The minute you have a perforation and a hole in the artery, a balloon should go up and stop the blood from extravasating into the pericardium or the muscle. Then the rest of them, like covered stent, sometimes even normal stent can stop the perforation. In distal perforation, you could use coil, thrombin, or fat embolism. And then the most important part, if there's any hemodynamic compromise and pericardial fluid, then pericardiocentesis can be life-saving. Reversal of anticoagulation, and then if things don't work out, then you might have to call the surgeon and take the patient to the to theater. If we go through this in kind of details, there are general principles. Any perforation has to be handled this way. Immediate balloon occlusion. The minute you see the perforation, you put the balloon up and stop the blood from flowing into the artery and in turn into the pericardium. And of course, it goes without saying, IV fluid and support. And if there's any pericardial fluid collection, if there's an echo, fantastic. But remember, fluoroscopy can show you the dye in the pericardium during angioplasty. If you look at the picture on the left, you could see the silhouette of the dye around in the pericardium. And you know if there's any hemodynamic compromise that you need to do a pericardiocentesis. And do not reverse the heparin, because this is the first thing I hear every time whenever there's a perforation, reverse the heparin. This is a mechanical problem that needs to be treated. You reverse the heparin, you've got gear in, you're inflating the balloon for a long time. You could run into trouble by causing thrombosis. Do not reverse the heparin at this stage. Once you've put your balloon up, you could leave it for a few minutes and then you check. If the extravasation has stopped, then that's good. You monitor and you repeat the echo. If it continues, then you have to look at the cause and treat it, whether it's a proximal, large proximal vessel perforation, which will require a covered stent, whether it's a distal vessel perforation, which require embolization with different things. We'll come to that in a minute. And whether it's collateral perforation, and this is one of the difficult one, where it will require a bilateral embolization because of the feeding vessel. If all fails, of course, that's when you could reverse the anticoagulation, then inform the surgeon after removing your gear. So if we look at the proximal vessel perforation, you balloon tamponade it and you need to use covered stent. Remember, these are bulky and difficult to deliver. And of course, the perforation often happen in calcified really resistant arteries, so poorly prepared, so you might not be able to deliver them. You could use a guide extension, but you need to be aware and really familiar with the compatibility, because not every guide extension will accommodate larger size covered stent. Sometimes prolonged balloon inflation can achieve hemostasis in itself, which could be good, but really to be aware that it might not last. And there are extreme measures only for experienced operators that have been done. If the balloon tamponade cannot stop the perforation and the covered stent cannot be passed, then you could dissect around the area of perforation and tamponade it from the outside in the pericardium, then re-enter distally and stent through that way. And there are different covered stent. We used to have the graft master, which is quite bulky and two layers of metal and very difficult to deliver. Now we have much more malleable and small, compatible with 5 French, which is the Peperos and the B graft, and they are quite good, compatible with 5 French, except for the 4.5 and 5, which can require a bigger size catheters. They are made life much easier in terms of deliverability. You still have to be aware of the compatibility with your guide catheter and guide extension. And delivering the equipment, you have to keep the balloon up as long as possible until everything's ready. You tamponaded the artery, then you take a second wire, whether through the same catheter, a single guiding catheter, or what's called the ping pong, i.e. take a second guiding catheter and introduce it to the same artery. You get your covered stent ready on the second wire. Then when the wire comes to the inflated balloon, that's when you deflate the balloon, pass the wire, pass the covered stent, and remove the tamponade balloon, and then deploy your covered stent. This could become easy. And this is what we call the ping pong. In cases like when you have doing CTO, you already have two guiding catheter. But even with single guiding catheter, you have to be aware of size compatibility. You do the same thing. You introduce your wire, you cover the stent on this wire, and when you come to the balloon, you deflate the balloon, pass the wire, and then pass the covered stent. What about guide wire and distal vessel perforation? This is important to remember that even if it doesn't cause any problem immediately, it could have a delayed presentation up to 8 hours. And we know this from CTOs, so do not forget to monitor the patient if you see any wire perforation that you haven't treated. And this gets treated by microcoils or alcohol foam or thrombin, collagen, multiple things. And we have recently published a novel way, really economic, by using a balloon remnant. I cut the balloon in half and deliver it on the wire to the distal part of the artery to block the occlusion. Occasionally, you might have to use a covered stent across the origin. And you should be familiar with the coils. There are pushable coils and detachable. The detachable ones are more easy to control and to know exactly where to deploy them, so you don't have any mishaps and deploy them in the wrong place. These are usually delivered through microcatheters. Some of the microcatheters have to be a bigger lumen, but there are micro coils that could be delivered through the microcatheter we use for CTOs. Balloon remnant, this is a case we published recently. As I said, we didn't have access to the coils immediately, so I cut part of the balloon, as you can see in picture D, put it on the wire and use a second balloon to deliver it all the way distally, as the schematic picture shows you, and you leave it there. Important to make sure that the balloon has passed already, because if you put this cut balloon on the wire and you push it, there's no retrieval if it doesn't deliver where you need it to be. So you need to make sure that it has delivered before, i.e. a balloon has passed through the lesion. What about collateral perforation? These really could be a nightmare because they are very fragile, and if they perforate, it could lead to a rapid tamponade. And they will require bilateral approach and closure because the feeding arteries are from both sides. And sometimes it's difficult to identify where's the feeding branch. So you might have to use a balloon on occasion to block some of the branches to see whether the extravasation or the bleed is stopped or not. Then you could coil them. Occasionally, if you have a microcatheter in place, you could apply negative suction, and that allows the bleeding to stop because it collapses the collateral. And you could use the indeflator for that. Here's an example that I've done a case. I opened the circumflex retrogradely, but the collateral ended up perforating at the end, and I had to go into the diagonal that providing that collateral to coil it. And then go back again anteriorly, and the artery that I opened after all the effort had to coil it distally to stop this extravasation from happening and to save the patient from tamponade and low blood pressure. What about anticoagulation? Anticoagulation, as I mentioned, the first thing people say, reverse heparin. That should not happen, should not be the first step. This is a mechanical problem that needs to be treated by covered stent, by coils, whatever is needed, as we mentioned before. And only you reverse the heparin after you remove your equipment. There was a series that showed of the 132 patients, up to 38% of thrombosis in these cases if you reverse the heparin. But if you come to the point where you need to reverse the heparin, it's the protamine, and it's usually 1 milligram of protamine per 100 units of heparin used within 60 minutes. And the maximum dose usually is 50 milligram, and you have to give it really slowly, at 0.2 to 0.3 mil of the 100 unit per milliliter concentration. You have to do it slow, and you flush it, and that usually reverses the heparin effect, and you are able to help to stop the bleeding. So in general, if we look at this, there are the general principle, as we mentioned before, balloon tamponade, number one, and then IV fluid and support for the patient, and then pericardiocentesis if required. On occasion, prolonged balloon inflation can stop the bleeding, but you need to know your equipment really well, and you need to know the compatibility, particularly for the covered stent. In previous bypass operation, early treatment is paramount, because they could deteriorate quick because of the loculated fluid that cannot be reached percutaneously, and they may require surgery. And again, remember, do not reverse the heparin until your equipment are out. Really, when you look at this prompt diagnosis, immediate balloon inflation and pericardiocentesis, subsequent management will be tailored according to the type of perforation, as we mentioned, whether proximal, distal, or collateral, and the perforation kit has to be ready. You need to know the equipment and the compatibility. Only consider reversing the anticoagulation after pulling the gear. And remember, every coronary perforation has different behavior and prognosis according to the patient clinical status and anatomical setting. You need to be prepared, meticulous, and careful. And if the complication happens, then you deal with it. You need to be ready. Learn how to use all the management options so you can choose what works best for that particular patient. Have a plan for your particular patient before you have the complication. This comes from knowing the patient and being prepared for the worst, but hoping for the best. And I finish by saying the best gear is your brain. Really use your brain and be ready for dealing with any complication. And always show your superior judgment so that you do not have to show your superior skills. And know when to quit and return another day, because there's always tomorrow. And with this, I'll say, thank you very much, and I'll be more than happy to take any questions. Thank you.
Thank you very much, Muhammad. Good morning. Early morning, huh? So thank you very much for being with us. Great talk presentation. We enjoyed it, and we have with us the panelists, Dr. Umar Gochkin and Dr. Walid Kadro, and all the colleagues, friends are here, and we enjoyed your talk. So. Walid, any comments, please, to the Dr. Muhammad's presentation, perforation and tips and tricks?
Anyway, thank you very much for really a nice coverage of the topic. Just I want to ask you about your experience with those detachable coil. I know the pushable coil is, but the detachable coil. So do you handle it through the microcatheter, or you can do it through the guiding catheter and then adjust it with your hand and then do the detaching?
No, you have to do them through the microcatheter. You can't do them through the guide catheter. So they have to be delivered through the microcatheter. And once you reach the place that you want to release them, then you release them. They could be released electrically or mechanically, depending on which one you use. But yes, you have to deliver them through a microcatheter. Suppose what I was going to say, I did repeat myself 2 or 3 times about 3 subjects, but the compatibility, because this is what I've seen many, many times. People try to deliver a covered stent in a small guide and find it quite difficult, or a guideline or a guide extension, and also reversing the heparin. The first thing you hear from anybody, the minute they see a perforation, say to reverse the heparin. So I apologize if I repeated that many times, but I think it's quite important.
No, it's clear that reversing the heparin should be after you took everything out. So you decided if you leave any wire or any hardware inside the artery and reverse the heparin, that's very high risk of thrombosis. So if you reversing the heparin after you take everything out.
Yeah.
And that's the message I wanted to get, because every time you hear this, the first thing people say reverse heparin, and that's not the case.
Okay, Dr. Musa Akbar, you want to have a...
Good morning, Dr. Mohanad. Thank you very much for the nice, elegant presentation. Could you explain more on how you do the technique of cutting the half balloon? What is the size? Do you inflate it slowly or just deliver it? Just what's the tips on delivering the balloon for distal perforation? Thank you.
Right. So this is a half a balloon. And as I said, because at some stage I wasn't patient enough to wait for the coil to come to the lab, I cut half of the balloon. You cut the half of the balloon, but you have to make sure that this half balloon will go through, because if you have burst the balloon from before, then you know it's going to go. You mount it on the wire, and you take a second balloon, and you just push this remnant or half of the balloon all the way down to where you want it to stop. And you have to stop just before the end, so it doesn't exit from the port, basically. But yes, you mount it on the balloon, and you take a second balloon, and quite often it's better if it is a used balloon, because it'll be unfolded and it'll block the artery quicker.
So, Umar Jojkin, you are master of the CTOs. I'm sure perforation is part of your daily maybe life. You see, what's your lessons? Maybe you can, how to avoid this first. And because sometimes these are catastrophic, you go into the, and Dr. Mohanad mentioned the operator aspect. You mentioned technical, mentioned the clinical feature of the patient, and mentioned the operator. So maybe you can comment on that as well from operator point of view.
Yes, thank you very much, Mohanad. It's great presentation, and thank you. It's really early in the UK. We know that. Thank you for you get up early for us. Thank you very much for that. So I think. First of all, I like this balloon embolization a lot, and I use it for the distal perforation, especially wire perforation. It's really quite, to me, cheap and doable tips. I do it in my lab. And yes, I think the perforation is important to know how we should deal with. I think. Of course, the most important thing is to prevent the perforation. For the distal perforation, we have to, we have to be very careful about our wire. We never do knuckle wire if we use hydrophilic wire. We never knuckle that. If we work in the small branch, we should be extremely careful because it's easily perforated distal vessel. I will show you one case today, and. For the proximal perforation, sometimes, you will have it because you fight with the calcification. When you try to break the calcification, you might have perforation. So it's maybe part of our work for the proximal, main vessel perforation is different than the distal perforation. For the proximal perforation, you have to be careful about the size of the vessel, of course. You shouldn't do dilate the vessel. This is, I think, important. If you have proximal perforation, I would strongly recommend ping-pong technique to send another guiding to send graft stent. This is very important because proximal perforation, you might have severe bleeding. So I think this is very important. And we have to be very fast if we have perforation. We can lose patient easily on the table. Yeah.
So Mohanad, when this perforation happen, there is effect on the patient and effect on the operator. With somebody like you being experienced in this field, maybe you can go back some years back when you had this perforation and bad outcome. What feeling people go through and how should they come out of it? Because I know friends, who lost patients. They also gave up from doing any procedures. So maybe you can also help us in that aspect from how to recover from these.
Yeah. I mean, I think it's quite an important point because dealing with you feel that you get that sinking feeling in your heart when you see this perforation. It's quite a dramatic thing, so especially with the bigger one, LS3, or if it's perforated into a cavity. I mean, of course, experience comes. We always know that good judgment comes from experience, and experience comes from bad judgment. We all have been through where we started doing things we shouldn't in our old days, and then you slowly, and this is what I started before I talked about the perforation itself, started about the complication itself, by being prepared, being meticulous, and looking at each case, because experience has told us when you have a tortuous artery with calcium, there's a more chance of perforation. So when I inflate my balloon, I always, before I take it out, even if I revert it, brought it back to the guide catheter, I take a little test. Because the last thing you want, and I've seen this again and again with some operator, you take the balloon out, you're talking to your assistant, you're kind of taking your time, you turn around, take a little test, and there's a perforation. And there's a time lost in here. So basically, one of the important tips, if you're dealing with a complex case, before you remove your balloon from the catheter, just bring it to the guide catheter, leave it there and take a little test, or even a cine. So you know that. One of the important things when complications happen, because we always learn from it, is to debrief. Really, when you finish, and I mean, hopefully you were able to manage it well and to deal with it well. You debrief and look back at the case. I always go back and look at what I have done and why. Often we find that we have cut the corner, or we've done something we didn't pay attention to, and you try to learn from all your mistakes. But whatever you do, complications are going to happen. And again, I said that at the beginning, you need to own it, and you cannot be in denial. You just have to see and deal with it, and build the experience to try to avoid any complications.
Great.
Hi, Dr. Mohanad. Thank you for the nice overview on perforations. I just have one question, because I've dealt with this issue before, and I wasn't sure what was the best way to go about it. So if you have a large vessel perforation, you know, especially when you've done like balloon dilatation, you know, it's like a fibrotic segment or a calcified segment, and plan was like to stent it, but you ballooned it with whatever balloon, cutting balloon, NC balloon, and it perfs. And then it seals with prolonged balloon inflation. After that, after it seals, obviously you're happy, everything went, you know, you managed it. Do you actually stent it? Do you stent that segment? Because you've really ballooned it aggressively. And if you stent it, you may, you know, the healed segment may perf again. That's my concern when it comes to those kind of lesions. Do you actually stent, I mean, put just a stent there and hope for the best, or do you just wait maybe a day, bring him back, and then stent it?
Excellent question, because again, I did touch on this slightly. The deliverability of the covered stent obviously is very difficult, and sometimes even normal stent can seal the perforation. But if you feel that the lesion is not well prepared, and the perforation or the extravasation has stopped, there's nothing wrong with stopping and coming back. Because the last thing you want to do is you created a problem already, and it's kind of got controlled, i.e. the perforation stopped or the extravasation stopped. To put a stent that's going to be under-deployed and undersized and under-deployed, you are creating a problem for the future. If the patient is stabilized and there's no more extravasation, there is nothing wrong with stopping, and you could always come back. You could leave it for a few weeks for things to heal and come back and prepare the lesion with rotablation or laser, whatever it is, so you know that you are going to have a good outcome at the end. Because if you put the stent as under-deployed, it will thrombose or occlude, and that's not what you want. Sometimes you have to do it, i.e. if the extravasation is not happening and you try to use a normal stent first and to deliver it in. But yes, there's always tomorrow, and there's nothing wrong with stopping and coming back.
Thank you.
Walid, you want to say something?
Since our speaker is coming from the Freeman Hospital, whenever I hear about the Freeman Hospital, to my mind come two important names that we need to remember. Dr. Desmond Julian, with his famous cardiology book from the British, and the other one, Dr. Ronnie Campbell, who died suddenly in 99 just suddenly from a heart attack, and he's one of the major. And now we have Dr. Mohamed Ajrat from the CTO people, and we keep that in mind as a major person from the Freeman Hospital.
Great.
I hope that you remember those names.
Yeah, great information.
Yeah.
So we'll move now to Dr. Umar Gochkin, and Dr. Umar is well known in the field of CTO and actually complex cases, and take us through his complex case or complication case, Dr. Gochkin from Turkey, please.
Thank you. Thank you, dear Abdullah, for inviting me for this very important, I think, and educational meeting. So I'd like to present you a case. Actually, I supposed to bring another case to you, but my colleague had, in another hospital, had very interesting perforation, so I changed my patient to this patient. I see that quite interesting patient. I hope you enjoy. So the patient is 61 years old male. This patient has brother of the head of the hospital, that hospital. So very good operator, a friend of mine works there, and he did the case. They called me sometime during the procedure, so that's why I know the patient. So he's smoker, hypertensive. He has no diabetes. He has class 2 angina. He had angioedema in 2020. He had primary PCI for proximal LAD, and he had elective PCI for right coronary artery. And plan was coronary angiogram and PCI if needed. This is the right injection. You see that there is a mild restenosis in the stent. In the left injection, they see severe stenosis. I think this is high OM rather than intermediate artery. There's severe stenosis, and they think that the pain could be from here, but also they wish to treat RCA instant restenosis, although to me it's mild to moderate. This is another view. There is a LAD stent, which is okay. There is distal plaque of left main, which is not too bad. So they did predilatation, they did dilatation for instant restenosis by 5.0 by 12 and C balloon, and this is the result. Okay, right coronary done by that balloon, and it was perfect result. And then they tried to treat this high OM, and then the first they did predilate 2.5 balloon, and then they implanted 3.0 by 15 stent. So they try to stent from the ostium of the OM rather than come from left main to make it more simple. This is after implantation. From other view, they see some plaque of this ostium of the circ, and they didn't like it. And also there is some stenosis, it looks like, at the ostium of the LAD. It could be instant. I think it's instant. And then they try to put another stent from left main to high OM, which is 3.0 by 12. And then they did post-dilatation. And then post-dilatation was 4.0. So they revire it, of course, to do kissing, right? So if you compare with these slides and the previous one, could you tell me what is the difference between two, not this one, sorry. So this one, because the mistake starts here. So now they did pot, and they rewire it, and they did kissing. Sorry? Okay. Any other thing that you will tell me now? because there is something now, I think, as operator, we should aware it in the procedure. Wire, yes. Wire is not the LAD now. Wire is in somewhere. After they do rewiring, they didn't check where is it going, and the wire went to diagonal, and diagonal is quite small. And also, the wire is knuckled. Although this is run through, it's knuckled wire. So this is I think the problem starts. They didn't see it yet. And after that, they did, after port, they saw a staining, right? So they understand, yes, they did some perforation, and of course they look very carefully. The operator is quite experienced operator, I tell you. So they see it, of course, they checked it, and at 14:09, the time, they see it and they checked it. Okay, so they waited some time. They do another kissing for some reason, bigger balloons, while they're waiting, and they do pause. And then, after almost half an hour, okay, there is some, my slides is a little bit changed for some reason. Anyhow, so they waited around 20 minutes before they sent the patient to the CCU. They sent the patient CCU after 20 minutes. There is no bleeding. There is no any fluid in the pericardium. But after 2.5 hours, patient had hypotensive, bradycardia, and cardiac arrest for 2 minutes. They immediately do drainage. They did some CPR, and then patient came back, and then they have the patient again. Then they saw the perforation. So this is very important, as Mohammed mentioned, wire perforation present later. There is a delay presentation if we deal with the wire perforation. This is a very typical example for that.
So Umar, before the image before this one, there were perforation, and they sent patient to the CCU. Just show us, because you showed us there is some.
Yes.
Yeah. So what stage? Just go back.
Here.
I can see.
Yeah, I saw that. I see what I mean. There's a perforation.
Yeah, this.
No, you mean here, right? Here. So they saw this.
Yeah.
What do? They saw this one. If you see this, you check by echo, you waited half an hour, you see nothing happens. What do? I don't know.
Can you, Doctor?
Of course. I don't know what happened in my slides, but these slides, there is changes this slide. I don't understand, really. Anyway, but they waited around 30 minutes in the lab, and they did kissing and port while they're waiting. Nothing happened. What would you do in that case? This is the appearance. The worst appearance is this, nothing more.
So the wire now, did they change again the wire from lower diagonal to the upper diagonal? Or where was the wire originally?
The same vessel. That vessel, perforated one. Okay. And if you come back here, please look at it here. This is the wire, all right? And this is very small artery. If I like to show you that, it's very small. You see, it's a small artery. This artery, very small one. They went that artery and with the knuckle wire. So it's easily perforate. Nothing surprising.
Basically, it is in the distal lateral wall for one of the distal diagonals. Okay. So even with the echo, they might not be able to see, because it's going to be localized. They will not be able to see where exactly. They should have taken like another view. Retrogradely now, like to see where the perforation is and how big it is, even after half an hour, because if it's a wire perforation, is going to take time for it, to leak and collect, and it's in the lateral wall, it might, distal lateral wall, it might not show basically. So maybe that's the thing, like if this happens again, people can recognize it, so.
Okay, and again, you see that the virus is quite deep with knuckle.
My question is, like when they waited half an hour, did they take a final photo, a final picture to see if there's perf while he was waiting in the lab? That's my question.
Sorry, say again?
So when they were waiting
Half an hour
in the lab, did they take a final picture after that and not without any wires?
Yes, of course.
They did, and there was no
nothing.
Nothing.
There is some contrast staining, nothing more. Of course.
Let us just ask this question: Would anyone do any coiling at this stage?
Yes, that is the question. That is the question.
That's my question, actually.
Oh,
Did you see it? Giving this presentation,
I
did you
wouldn't
see it?
personally. I look sometime, and and I look some personally. To be honest with you, I wouldn't coil this. Because we have this kind of staining, right? And we wait. Mostly nothing happened.
Omar, what is the chance of these progressing into tamponade? Obviously, it's not progressed, but if you see something like this one, what's the odds from your experience? I don't know.
You mean in that stage, or?
No, yeah. If I do an angio, if I look at this picture, what is the chance of such one progressing into a tamponade? I mean, obviously, a lot of times we see
it looks
the
to
minimal
me
perf and we leave it, and we keep the patient for some time in the cath lab. We echo them, and then we re-echo them when they go to the unit, and we keep eyes on them. But I don't know.
I mean, when you look the diagonal, it's not big diagonal; it's small diagonal. You may perforate, but I think it looks like that it's sometimes there is maybe some hematoma, obviously, but there is no, this is type 1, to me, type 1 perforation. Not easy to, if it is epicardial, of course we should be more careful. But in the I don't know, Mohammed, what's he thinking?
Step number 1 in such case, we will go through the algorithm, I guess. It's like checking ACT. Did they give a reversal? I mean, they give heparin
No,
maybe?
at that stage, no.
Anyone would give a reversal?
You will not give a, why wouldn't you give at this stage a reversible?
Check the ACT, give the reversal, it's a perf.
Yeah, because this case is in antiplatelets and anticoagulation, there is delayed onset tamponade. It can occur even from second day until fourth day. We have one case with very tiny perforation and tamponade occurring in the second day after 24 hours. So I think this case should be at least monitored for 24 hours by echo every 3 to 6 hours.
I think this is a very good point. In that case, or the case like this, we shouldn't discharge him next day. This is a very good point. I agree with you.
Dr. Omar, could you put a small balloon in the proximal diagonal, the one that perforate, and inflate it for a certain time to see if that will go the same?
I think that could be done. I think that could be done. But if there is distal perforation, most of the time it will not have that much help. If the distal perforation, if you have clear distal perforation, I would suggest to do something, either balloon implantation, which is very easy. I don't know if you do it. In my practice, it's very easy to bring their half cutting balloon. Very easy.
So Umar, just do Muhammad, you are with us, huh? Muhammad?
He's sleeping, maybe.
No, he's with us.
I'm
I think
joking.
you want to say.
I was just.
He was with us yesterday, even. So.
Can you hear me?
Yes, we hear you. Yes.
Okay, sorry. Yes, I was just put as an attendee, so I just asked to be. Right. Sorry. The question was, Omar mentioned something to me. I forgot what was the question.
So you see that the perforation right now, Mohammed? Yeah. So what happened? They have it, and they waited around half an hour. Nothing happened. They sent the patient to CCU to follow up, and then at that stage, what we can do, if you do anything, any coiling or anything at that stage, or proximal ballooning would help. What do you think?
I think looking at this, probably proximal ballooning is more than enough. If there's no pericardial effusion, I agree with you. I probably wouldn't be doing anything at this stage. But we have to be, you know, you have to monitor the patient. You have to repeat the echo and be very prepared to come back. Often in cases like this, if I think something might happen, I could leave the sheath in, take them out of the lab after half an hour after you tamponade it, and this is not progressing. You leave the sheath in and you monitor them on CCU for 2-3 hours. If nothing happens, you could take the sheath out, i.e. the radial or the femoral sheath where you performed your procedure. Otherwise, if something happens, you're ready to come back immediately.
All right.
But looking at this, yes, I agree. I probably wouldn't do anything. The only question I was going to ask, did the patient receive any 2B3A inhibitors?
Sorry, I missed the question, sorry?
Any 2B3A inhibitors like tyrofibran or neopro?
No,
right?
in this patient? No, no.
Yeah.
No.
Because that's the thing about also wire perforation. If you give any 2B3A inhibitors, the small perforation could become a big problem.
Yes, especially, yeah, even,
Inhibitors, quite often they don't need any intervention.
I agree. Even if you did tip perforation by the tip of the wire, not the knuckle,
Yes.
yeah, you might have a problem. Most of the time it's nothing, but you have, yeah, I agree with you. So, shall I go?
Yeah.
So after rewiring, this is the, yes. So they have now, after 2 hours, 2.5 hours, you know, they have it. Now the time is 17:55 after 2 hours. So 17:15. All right. So I don't know how is it possible, but my slides changed. I don't know. All right. So and control angio showed that's one. And now they did coiling. They did coil with 2O40 macrocoil. They embolize the vessel, and there is no obvious bleeding now. Okay, nothing. They did close the tip of the vessel, the distal tip of the vessel, very small coil, and what do you do now? I think the problem looks solved, right? Yeah. So, for some reason my slides changed, places changed. Anyhow, after 90 minutes, patient had again hypotensive and VT, pulseless VT. They did DC shock and they bring the patient to coronary cath lab again, right? So now there is a perforation, little proximal, okay? Typical delay presentation, proximal, because there is a damage of that vessel wall at that I will show you with the wire. There is a damage at the wall of the vessel. Sometime later it's perforated. Very, very interesting. And it could happen. So then they think that's what's going on. And so, yes.
Just to ask a question. Go back. If you go back, was that the correct diagonal that was coiled?
The coil moved.
Yeah, they coil it, but the perforation is proximal that coil. The same vessel, but more proximal.
Yeah, the coil probably has migrated distally.
Yeah, they push the coil more distal.
Yeah.
Maybe could be mistake because they could do it a little bit proximal. When I see, I went to cath lab because he's the brother of the head of hospital. The head of hospital is my friend too. So I went around to the hospital, and it's a very interesting case anyway. They called me and I said, please do this, and then they did it, and we saved the patient anyway. But this is the stage. Now we have bleeding, freely bleeding. So they think that it's okay. They could do more coil. They did more coil. There is no, so it's 1825 now. They checked it, all right? There is some staining, But this time there is free bleeding. Yeah, they always sucking blood from pericardium. Interesting. There is not that much bleeding, but they keep sucking and they give the patient back to blood. And then in here, I will show you. I don't know why my slides changed. Anyway. Right. So they put more microcoil, trio, 60, 40, 30, and 3.5, 80. But there is still some staining. They think that it's because of that, because they have bleeding. They think that what's going on? They did it, there is some staining, and they think it's, what can you do if you couldn't close this artery? I think you can put, and you see lots of blood coming. And I think you would do the same thing. They implanted one graft stent to close origin of the diagonal. They did it. This is graft master, trio 2.8, 2.8, 16, and they did a trio post-dilatation. This is the result. So there is no vessel. There shouldn't be no bleeding, right? But there is bleeding, very heavily. That stage, they called me. We didn't understand. They said that we didn't understand. We coiled everything. We closed the door, and there is bleeding. And I said, please send the patient surgery immediately, because I will discuss with you, but I think something, and we saw it's happened. So what do you do? Of course, in this stage, we do nothing. Okay, surgeons should come, right? Because it's still bleeding. And then, anyway, still severe drainage, and now tachycardic, hypotensive, and they checked right, you know, because they did something right as well. So they think they checked the right. Right is okay, nothing. And then they checked possible source. They checked first if the pigtail is somewhere in RV or LV, because free bleeding, you know, we should think about it, but it's in pericardium. Pigtail is in the pericardium. And they checked also later on LV, you know, this is in, you know, pericardium. And anyway, the patients had sent the surgery, and they found hole in the right ventricle, inferior wall, done by sheath when they tried to puncture of pericardium. It happens. If you have free bleeding, we should definitely think about it. We made a damage RV. It could happen. So, and they saw a hole, and then of course they fixed it, and the patient became well. And now I think he will discharge today. The patient will discharge. If you look carefully, you see, and this is the point. This is the distal side of the perforation, but we have another damage area done by, again, you see, there's a small perforation. Definitely there is something there, but how can we know that it will be freely open and not easy to know it, to be honest. But once you coil it, I think you had better coil from the proximal. I think this is the lesson of this case. When we coil, we have to decide where we should coil. You know, we shouldn't, maybe we should, I mean, if we have damage at the proximal, we shouldn't go that much distal. Because this is the place, second perforation. You see, that's the same area. So this is my case. If you have any question or comment.
Thank you very much, Dr. Omar. Any questions, comments, maybe from the panelists first?
Well, just I remember a quote, and I'm quoting one, I'm sure everybody knows Dr. David Holmes from Mayo, when he taught us as fellows for the complication. He said there are two kinds. The one IWIH DT and the stent. I wish I haven't done that. And that's, you know, when you are doing larger balloon and you see that you got perforation and you recognize and try to. But there are something that you are not expecting, and he called that SHET, and that's so this is the difference between what you are expecting and what you are not expecting.
Khalid?
Well, I guess the RV puncture happened during the insertion in the CCU when they tried during the CPR.
Right.
So it's going to be difficult because during pericardiocentesis, if it was a very small and causing tamponade, the perfect thing is having a pressure line in the needle and also having the electrode just to make sure there is no ST elevation when you go in with the, especially if it was a small. It's available in all the pericardiocentesis set where there's the electrode, so you can see the changes in the ECG. If you puncture, it will show. The second thing regarding the pressure, because once you go through the RV, you're gonna see the RV pressure waveform coming to you, but this is inevitable. I mean, it happened during when they were inserting the pericardiocentesis set. So these are two tools when you are doing pericardiocentesis with a very small and it's causing tamponade. You have these two, the pressure plus the electrode connected. It will show you if you're going through the RV. So this is, I think, one of the tips that could help also.
Yes.
Yeah, two comments. I think the first coil should be more proximal than this place. Yeah, even if we don't recognize the second perforation, should be more proximal, because any instrumentation and the manipulation distally in very small caliber capillaries can cause even rupture of these small capillaries. Second point, as regard to pericardiocentesis, I think in the acute situation, acute perforation or like this, the accumulation is very fast. So the amount is very small. So the echo-free space is very narrow. In this situation, always we don't advise in our center. It should be done under echo, pericardiocentesis under echo guidance, and expert one, he should, because he just playing in very narrow echo-free space, maybe 0.5 centimeters.
Very true, yes.
So it's very interesting case, you know, and really,
Can I
Omar.
just, sorry,
Yeah,
can I make a comment?
go ahead, yes, please. Go
Yeah,
ahead.
just about the coiling. Yeah, absolutely, that should have been proximal, but in order to make the coil work, I think you need at least the size has to be a little bit bigger, 1.6 to 1.8 if what you think the vessel size is. And you probably, quite often you need more than one coil. Of course, I notice here they've used the longer one, and the longer one, what they tend to do kind of spread inside the artery. There are the kind of the helical one that shape themselves, but usually you would need to choose the coil a little bit bigger than the size of the artery, 1.6 to 1.8, and deliver maybe one or two, and that will hopefully stop the bleeding from continuing.
Yes, very good point. It's another tip for that. If your coil is elongated a little bit proximal, you can push that coil with the wire, with O14 wire. You could be able to push that wire to more distal, with the macro coil to distal. So
it's like an insightful case, because they did balloon closure, and then they did the coil, and then they did the covered stent. You did everything, and then it ended up like having the RV puncture, and then the patient went to surgery. So a great case.
So when they told me they close everything, but they have free bleeding, I said that there is a hole in the RV. Please send it to patients.
So you came to know this at what stage? After the second, you know, they did the first coil, they went back, then you thought about that, or because we don't want this to happen again for us.
They call me saying that, Omar, we have a perforation, and he said that who's he, and then they have a perforation, and they close everything, but they have free bleeding. So in that case, please send the patient. There is a hole in RV.
Yeah. Omar, this raises a really very important point about asking for help and asking somebody else. When you are kind of engulfed in treating a perforation or any complication, you become almost tunnel vision. Because here you go, here they are,
Yeah.
they put the artery, there's no flow in the artery where the perforation was coming from, and yet the patient was still having pericardial blood and still having hemodynamic compromise. And probably they would have spent a little bit of time before thinking, or the belly drops, or the lights kind of shine, say, oh, there's something else. When they called you, because you're kind of fresh and you have a different look, you immediately say, think about something else, which is the RV. And this is often what happens in complication. It's a stressful situation. Everybody is quite stressed, focus on one thing and one thing only, that's to treat that complication with some other reason. And somebody with a fresh eye comes in and have a look and maybe makes a huge difference in terms of their recommendation of the CN thing. So I think it's quite important to have a second look.
Great. So from the first coil, I think everyone mentioned to be more proximal. Then second time, you need to think not just at the same place, something else. A very interesting
I
case.
think that the delayed perforation is a good example. There is just damage, but after 2 hours you have free perforation. This is a very good case to see.
So thank you very much, Doctor.
It's happening. Thank you.
Okay, thank you. We'll go to Dr. Shireen from Bahrain, as recorded that as well. Intervention cardiologist from Bahrain.
First of all, I would like to thank the organizing committee and the course director to give me that opportunity to present today. My name is Dr. Shireen Sheikh. I am a consultant invasive cardiologist from Mohammed bin Khalifa bin Salman Al Khalifa Specialist Cardiac Center in Bahrain. I'll start my presentation with a case presentation. This is a 74-year-old gentleman whose known case of type 2 diabetes mellitus, hypertension, hyperlipidemia, a chronic kidney disease stage 3. He was referred from another hospital where he was admitted there with an ACS, non-stay elevation myocardial infarction. At that time, his ECG showed normal sinus rhythm with no ST segment changes. And his echocardiogram showed mild LV dysfunction with an ejection fraction of 50%. He has an inferior and lateral regional wall motion abnormality. His initial diagnostic angiogram, as you can see, has a diffuse calcified disease involving long segment of the LAD, the med, and the distal, involving that also large diagonal. He has also lesion in the proximal segment of the LAD. We can see the diffuse disease in the obtuse marginal, focal disease in his mid segment of the circumflex, and also the distal circumflex after the origin of the first obtuse marginal. His RCA is a dominant, small in caliber, diffusely disease, mainly has a tight stenosis in the mid and proximal segment and diffuse disease distally. So he was advised a surgical intervention, bypass surgery, but patient declined that option and he preferred to have a PCI. So we went ahead and did an IBIS guided intervention for his circumflex and obtuse marginal, using a Collot technique and DCP for the distal OMs. And this was the final result. He was admitted again for a stage PCI of his RCA. And at that time, we used a 6 French 075 AL guiding catheter, BMW wire across that tight stenosis and placed distally. We tried to predilate with the small balloons, 1.25 over the wire balloon and 1.5 to Zuna balloon. But we had a great difficulty in advancing any NC balloon. Even the microcatheter, as we used here as a turnpike spiral microcatheter, got stuck at that mid segment of the RCA. So at this stage, we decided to rotablate this vessel. So BMW wire was exchanged to a floppy rota wire. And then rota was done using 1.25 per. Of course, we put a TPM before we proceed as a prophylaxis, as a backup in case if patient had any complication or bradycardia. After that rotablation, we went ahead and did further dilatation with a 2.0 and 2.5 NC balloon at higher pressure. And then we went ahead and did an IVUS, trying to understand and make sure about the lesion. So we had a diffuse disease in the distal part of the RCA with a reference vessel diameter of 2.5. We had that tight, and we had 360 degree of calcium in the mid segment, and the proximal segment of the RCA has a reference diameter of 4 millimeter. So we decided to go ahead with DCB, drug-eluting balloon, for the distal vessel using 2O30 millimeter. Distal RCA or mid-distal RCA was stented with Zions 25 by 23 and was post-dilated with a 3O NC. Then overlap proximally using a 35 by 33 Zions stent and was post-dilated with a 4O NC balloon. You can see here, this is stent boost or stent clear. You can see the amount of calcium and the waste in the stent and deformity slightly in the stent strut. So this is after deflating our balloon. You can see the amount of contrast outside the vessel. So directly, we re-inflated the balloon at low pressure. We waited for 5-10 minutes and reassessed the situation. And still, you can see the extravasation of the contrast from both, actually two origins, from the medial and lateral side of the RCA. So at this stage, we decided we need to cover stent this vessel. So we use papyrus, the 35 by 20 millimeter at 10 ATM, and post dilated with NC35 at 18 ATM. So this is the final result. You can see no more extravasation of the vessel and good TIMI flow distally. During that event, patient had chest pain, but he was reasonably hemodynamically stable. Immediate bedside echo showed no significant pericardial effusion and no evidence of tamponade. 4 hours later, echocardiogram was repeated and also showed no evidence of pericardial effusion. 24 hours post-procedure, patient developed pericarditis, for which he was treated with colchicine. If we go to the coronary perforation calcification, the famous one, ALIS calcification. So type 1 is the extraluminal crater without extravasation. Type 2, you can see the pericardial or myocardial blush without contrast jet extravasation. Type 3 is the extravasation through frank more than 1 millimeter perforation, which I think this is the case in our case. And type 3 is the perforation into the anatomical cavity, chamber, and coronary sinus. There are several predictors of coronary perforation: clinical, technical, and angiographic factors. So any clinical factors, we have the advanced age, we have the female gender, ACS presentation, and renal impairment. Angiographic factors, we have the CTO, calcification, type T lesions, eccentric lesions, and tortuous vessels. Technical associated factor, using stiff wires, atherectomy devices, high balloon to artery ratio, IVUS guided PCI optimization with a high pressure and cutting balloon. And clearly, our case had multiple factors as presented here. So in a class 3 perforation, as soon we recognize it, we have to do a balloon tamponade 1-to-1 ratio with a low pressure. Call for an echo, anesthetist and surgeon for backup. Be ready for pericardiocentesis. Reassess the situation after 5 or 10 minutes as the patient symptoms allows. And check if the perforation sealed, this is good, but if failed, we have to think about cover stent. Using cover stent, either it will seal the perforation or sometimes it fails to seal the perforation. In such cases, we have to either to do post-dilatation with a higher pressure, reconsider the site of perforation while inflating the balloon, injecting and see where is the origin of that perforation. Consider a second cover stent. And if failed also, we have to consider surgical intervention. So cover stent implantation, how we can do it. In case of 6 French guiding catheter, if the balloon is inflated at the perforation site, we can use a second guiding catheter using a second arterial axis, like a femoral axis, and use a parallel guide wire and deploy that stent or cover stent from the new axis. If we're having 7 or 8 French guiding catheter, if balloon is inflated at perforation site, we insert another second guide catheter wire in the same guiding catheter and implant the cover stent. If balloon is out, we can insert the cover stent directly. So in summary, perforation or coronary perforation is an infrequent complication, but still can be high or can be associated with high mortality and morbidity. The key points in management are prediction, preparation, and recognition. You have to predict while knowing the anatomy of the patient and the clinical factors that this is a high chance of perforation. You have to make sure that the required tool in your cath lab, okay? You have to make sure about the cover stent, if it is available in your shelf and what sizes is available. And of course, as soon as you see it, you have to react on it. Know the coronary perforation management algorithm and manage the patient according to the perforation class. And thank you very much.
Thank you very much, Dr. Shireen. Great presentation, and thank you for being with us live. Now we have a question from Dr. Umar, I think, at the beginning. You want to know Dr. Shireen with us?
Yes, Shireen, I'd like to ask which size was the balloon which perforate the vessel? Is it 3.5 or 0?
It's no 4.0 balloon.
4.0, right. But the IVUS shows that is it 4.0 vessel anyway, right?
Yeah, from the IVUS, it shows that the proximal part is 4.0 diameter. So this is why we put a stent of 3.5 and we post-dilated with a 4.0. But unfortunately, this is what happened. The good thing that we do always, if we recognize that calcium in the IC stent or stent boost picture, you can see the nodule of the calcium is there. As soon as we deflated the balloon, we did this perf angio, and we recognized that perforation. And in the same balloon 4.0, we tamponated with low pressure, and we waited.
To be honest with you, we have high risk for perforation in that case, that particular RCA, after seeing undersized stent. And if you do 4.0, we have to be very prepared. You know, stent graft has to be in the hand, just waiting. We should ask, open the graft stent. I mean, it has to be on the table, not opened, but it has to be in the hand, because I see it's quite risky. But we should open it. If you stented it like that, if you don't open that stent, you will have restenosis anyway for some time later. So we should do open somehow.
So, Dr. Shireen, that lesion when you preparing, and were you happy before you stent? I mean, I know it's just retrospectively speaking. You did the ballooning. Were you happy to stent at that stage, or you think you would have done more job, maybe if you, for future, for us to learn from this case, would have prepared more, or if not able to prepare more, maybe just do DCB, and invest for future. What do you think of that approach?
That segment in the IVUS showed that there is a 360 degree of calcium. And maybe the mistake was not really after that cracking or post-dilatation of the rotablation. We didn't repeat again the IVUS and see, is it really a cracking of that calcium after the post-dilatation or not? So this is maybe the mistake, if it is really help us later on, if we really prepare the lesion before putting that stent. But unfortunately, we bought the 2.5 distally and then overlap with the 3.5. I can see it clearly that waste, and I was really worried that the cover stent really will not really pass that segment and stent to inflate it or to implant that stent. But alhamdulillah, we are lucky at that time that it is across that lesion, and we post dilated with the 3.5.
Excellent.
Can I make a comment, please?
Yeah, Manet, go ahead.
Yes, sorry, 3 comments actually, in fact, a very good case and very educational case. The first one is, I think, when you're trying to do rotablation, quite often, the best thing to do is to size the rotabur according to the artery. This is a 4-0 artery. Passing a 125 will modify the calcium, but probably will not prepare it very well. So for me, if I'm thinking this is a 4-0, I probably would have upgraded the burr a little bit more, got up to 175, the second burr, because quite often, the 125 may make some modification, but it doesn't give you what you aim for. The second one, the images you showed of the stent, where you said it's damaged, and this is exactly where I probably would not have post-dilated. Easy to say right now, but if you look at that, you can see that the stent is expanding and where there's no calcium and it's almost broken. You put a balloon to try to expand it a little bit more, and the next thing is going to happen, perforation. And the third important part, if you put a covered stent, it's important to post-dilate it to high pressure. One of the most important ones to do is to post-dilate it to high pressure to make sure that it's well opposed and seal the perforation. But yes, for the rotablation, I think sizing the burr by 0.6 to 0.7 of the artery would make life much easier.
Great. We have 2 other comments, please.
Yeah, I think, thank you for the presentation, first of all. I think the mid-RCA was a 3.5 vessel based on the IVUS. So the 125 burr, as Dr. Mohamed said, it's not adequate enough to prepare the lesion. And you can see 360-degree calcium. What you should have done, as he said, either with a bigger burr or you do rotatripsy, like you do shockwave to get that concentric calcium really modified so you can deploy your stent. Or you would go with a cutting balloon or a 1-to-1 NC 3.5 to prepare that lesion. I think that was the mistake done here. But then you handled it nicely when you had the complication.
Great. Another comment here?
Yeah, I just want to add this comment, which is rotatripsy, which is very important actually, when we're using a small burr to make well preparation of the lesion. This is heavily calcified lesion, so we need to well prepare this lesion. If the burr is failed, we can use another lysotripsy balloon to well prepare the lesion. Second point, I noticed in the stent post, there is a little bit, as I noticed in this picture, stent fracture. I think there is a stent fracture as the lateral aspect of the artery. This with NEC balloon you're using make perforation. This is my explanation.
I think that the lesson of this case is we have to make sure, even with the rota, we have to make sure that we open the artery, properly. Maybe we should. Shirin, I think you missed some part that your balloon predilatation balloon didn't open well, and I think you missed that. That's why you insert your stent. Otherwise, you wouldn't do it. I think we have to make sure after rota, we do proper NC ballooning, and we have to make sure, you know, we open the artery. If we fail to open the artery, either we should use shockwave balloon if we have it, or we should maybe use stronger balloon, or we can do. But in that case, Mohammed, I am not sure if the bigger burr, even bigger burr, would do something, because it's circular, and there is, you know, lumen is not that small. You know, I think the only thing we could do is either a stronger balloon, NC balloon, or a shockwave in this case. And another thing,
you may be right, but I think quite often in these cases, using an extra support rotowire to create a selective bias that you wanted to, so the burr will touch the side of the artery. And I think we talk about shock rota, or, you know, using IVL after. Of course, that's quite costly, and to me, and we treat these cases many times. Upgrading the burr just gives you what you need. All what you need just to modify the calcium. So using an extra support rotowire will bias your wire toward the side. You do it carefully, obviously, to make sure that the calcium is affected. And then, as you said, you take one-to-one balloon, non-compliant, to be able to see that, to make that the calcium has responded, and then you should have no problem. But the telling picture, actually, as I said, was that stent, because you can see that it's fractured and expanded in that area much more than the rest, and that's where the perforation happened.
Another thing I would say is, regarding this case, although it's not related with the perforation, I saw that the Shireen did DEB at the first touch, and then stents later on. I would do, you know, distal balloon DEB or distal balloon massage as a touch of the vessel, because as we see here, after ballooning, the case is complicated. You know, I saw that the wire is knuckled already, so we might have easily distal dissection, because if you do something, any balloon, even if you do gentle, we might have easily dissection. So we should do distal massage or distal DEB as a last touch of the vessel after stenting rest of the vessel.
Dr. Shireen, your comments, maybe final message to us. I mean, we learned a lot from this case, and really thank you for sharing this with us. Maybe you want to say something. Khalid, you want to say?
No,
Dr. Shireen, go ahead.
It's a great case. Let's listen to Dr. Shireen first.
Please go ahead, Dr. Shireen.
I think my only point or message is you have to prepare your lesion very well before really committed putting a stent there.
Excellent. So we're looking forward to have you here and physically, inshallah, maybe with the GIS valve by Dr. Fawaz, inshallah, and 3rd and 4th of June, and Dr. Muhannad as well, of course. So thank you very much, all of you, and we'll now move to Dr. Musa Akbar and his session.